Thank you for joining us for Conversations, Cases, and Updates in Myelodysplastic Syndromes, practice-changing expert insights in lower and higher risk MDS. During this segment, we will be discussing updates in the therapeutic management of higher risk MDS. I'm Mikkael Sekeres, Chief of the Division of Hematology at the Sylvester Cancer Center, University of Miami, and Professor of Medicine. I am thrilled to be joined by my esteemed and famous colleagues, Dr. DeAngelo from the Dana-Farber Cancer Institute and Dr. Rami Komrokji from the Moffitt Cancer Center in Tampa, Florida. I'd like to start out by talking briefly about a case. A patient I saw recently was a woman who's a retired professor who actually came to me from the Northwest, who had higher risk MDS. She had a bone marrow blast percentage of 12%. She had pancytopenia. She had a karyotype that included a deletion 7 abnormality, and she had molecular abnormalities that were actually kind of in the intermediate risk category, a couple of those abnormalities. So I'm going to start off with a very easy question, and I'm going to direct it first to Dr. DeAngelo. Dan, how would you treat this patient right off the bat? And her age was 74 years old.
So 74-year-olds, it remind me of the blast count?
12%.
So, I think that this patient, meets that criteria for a higher risk disease. She's 74. And so based on, comorbidity, I'm still going to be thinking about the only cure is transplant. And can I get her there? And so I'm going to refer her to our transplant colleagues to at least get that going. Whether she ends up getting a transplant or not, many are called, not everybody gets answered. But then I'm going to initiate her on therapy. Currently, the standard of care is a DNA methyltransferase inhibitor, there are 3 different choices, preferably a clinical trial with adding a second novel agent. Of course, I'm waiting for the readout of several randomized phase 3 studies that I think you're going to discuss. But that would be my approach. Clinical trial, thinking about initiating a DNA methyltransferase inhibitor and referring her to one of my transplant colleagues.
So I'm going to push you a little bit. As you're referring your patient to one of your transplant colleagues, let's say they have their first availability is 4 weeks from now. Are you going to start your patient on a DNA methyltransferase inhibitor while you're waiting?
Oh, of course, yeah.
And what about you, Dr. Komrokji? Do you routinely treat your patients even when you're referring them for a transplant or with higher risk MDS?
In general, I would say yes. So, I think just to how I think about this, first I'll present the transplant to the patient. And I think in 74, I learned over time that patients decide whether they want to do that or not. Because I think the net gain of survival is there, but there are patients that look at me, are you crazy? I'm not going to go through all of this for a margin of benefit of 2 or 3 years extra survival. And some patients say, no, I want a cure and I want to live till I'm 100. So I usually let the patient decide. So that's a major point. But there is no doubt that the transplant is the only curative option. Nowadays, we transplant, age is function and comorbidity. So you could technically argue that there is no real limit. I think in terms of the management upfront, now, if this patient doesn't want to go to transplant, let's say I'm not interested in transplant, and they have adequate blood counts, I sometimes actually observe them. And we've looked at this, optimal timing. If somebody have adequate hematopoiesis, platelets above 50, neutrophils are good, whether we treated them immediately or after 100 days, there was no difference in the outcome. But in the setting of the transplant, treatment before transplant is a very controversial issue, obviously. And do you need a treatment or not? And I don't think we have a straight answer for that. My bias in general, most of those patients are cytopenic. The transplant is not going to happen in 3-4 weeks. That would be amazing. And that basically, if we reduce the blasts, maybe we'll get better outcome. Some people argue maybe the patients will get sick with the treatment you are offering up front and, delay the transplant. But in general, with the hypomethylating agents, patients do tolerate the treatment relatively well. So most of the time I start, there is really no good guidance. And that some of the transplant centers, they set those cutoffs of 10% blast or less that we are going to transplant. 11, you do have to do something. I think they're arbitrary. It's never been looked at systemically. In the past when they did chemo. There was no randomization, or the patients that had 19% blast got chemo, while 6% blast went to transplant. If you look at patients that got chemotherapy, those that went into remission, did better with transplant. With hypomethylating agents, it's never really been looked at a good response versus no. In the P53 mutant patients, I like to try to do something that brings that down. I think, as Dan mentioned, like if there is a trial access, I always prefer that as a first step. So that's my approach in general.
And I have to say, I agree. I always start these patients on hypomethylating agents when they have excess blasts, whether they're going to a transplant or not. Part of the reason I do it going to a transplant, I think there is some, relevance to the fact that reducing your tumor burden, patients probably do better at transplant. We don't know that for sure, but it makes intuitive sense. But also, life happens. Someone may say, I want a transplant, and they plan it, and then something happens where the transplant falls through, or a person changes her mind, or something else random happens in the many steps that have to lead up to a patient getting a transplant. And I don't want to be sitting on my duff waiting while that happens. So I'm going to ask you a follow-up question, both of you. I'll start with Dan. Which hypomethylating agent do you choose and why? Sorry, DNA methyltransferase. Dr. DeAngelo is very serious about calling these DNA methyltransferases.
Well, yeah, I'm tired of using hypomethylating agents when they're not a hypomethylator. But anyway, I still use azacitidine predominantly. That's where the survival advantage was seen. You could argue that Amir Zaidin's looked at the outcomes of decitabine versus aza; they're identical. I realize one's 5 days and one's 7 days. I have the option in the aza to administer it either sub-Q or IV. We're open on the weekends. It's less of an issue. So I typically will do that. I will look into obtaining authorization for the oral decitabine cytisiridine, but the cost is often an issue. So aza is still my go-to. I'm also very old-fashioned, but I'll agree that it probably doesn't make a difference.
How about you, Rami?
Yeah, I think Dan summarized it very nicely. We've used a lot of AZA. Many of the trials with the phase 3, the backbone is still AZA. Oral decitabine is appealing options for patients to take at home, but the copay has been an issue. So most of the time I do AZA. I think decitabine is very reasonable. The only time sometimes I'll prefer decitabine if patients have end-stage renal disease or their creatinine is very high. Decitabine is a little bit more liver metabolized, so I don't have to worry about more myelosuppression. People used to say, bring the issue that if you have P53, maybe you are more sensitive to decitabine. There was that New England paper from WashU group. I really don't think that's the case, and I don't think in the 10-day regimen is better than the 5-day regimen. So I think they are equivalent.
Right.
I not surprisingly agree with you both. Maybe I'm old-fashioned also, Dan, but I go with azacitidine as well, and it's my first choice because it's our level 1 evidence. We only have one prospective randomized trial that's ever shown a survival advantage for one treatment versus another for patients with higher risk MDS, and that's the AZA-001 study. Patients were randomized to get azacitidine versus conventional care regimens. 60% of those who got conventional care regimens got best supportive care. The remaining 40% got either low-dose cytarabine or classic 7+3 therapy. And in that study, the median survival for those who received azacitidine was 24 months versus 15 months for those who got conventional care regimens. The decitabine randomized study, which was also conducted in Europe, didn't show a survival advantage for decitabine at about 10 months versus 8.5 months. The problem, though, is that it's decitabine that was given old school, every 8 hours over 3 days intravenously, as opposed to how we do it now, what we can call the Steensma regimen of giving it over an hour daily for 5 days in a 28-day cycle. So we kind of squint our eyes and shrug and say, well, they're probably equivalent. They should have worked the same. We have Zaidin's study, which really looked at SEER Medicare databases. So it wasn't a randomized trial. It was looking at registry data to say it looks like patients did about the same on either one of these. But I don't know 100% for sure. So then we have the oral decitabine cytisiridine, where it's using even further indirect data. So now it's not even comparing it to something directly. It was patients who were randomized to get decitabine intravenously versus the oral decitabine cedazuridine, and then they crossed over after one cycle. So it was really a study looking at PK/PD data, and that's how it was approved by the FDA. So when I have this conversation with my patients, I do start personally with azacitidine. I will talk about decitabine. I have a couple of patients, for example, my patients who go back and forth between Latin America and here, who need something that's a little more portable. I will use the oral version in them. But again, I think I'm like the both of you with azacitidine. Now, let me throw one curveball to our initial case. Same 74-year-old woman, 12% blasts, but now in her molecular profile, she has a TP53 abnormality. Does that change what your recommendations are?
I'll start. No, it makes me. I'm less. I'm become more of a nihilist in terms of referring to transplant. I'm not sure what the role of transplant is for my TP53 patients. I will make the referral, but I'll be very honest with the patient, saying it's not clear that there's going to be a benefit, and if there is a benefit, it's going to be a very small one. We learned at ASH that even the addition of venetoclax, although it may improve the initial response rate, does not improve the overall survival rate. So I think a standard DNA methyltransferase inhibitor, AZA is my choice, as we've already elucidated, and that's what I would do, and to have a very frank discussion with the patient.
How about you, Rami?
Yeah, so just like to mention a point that I think, when we talk to our patients, and I think Mikkael and I, we looked at this in the MDS consortium, that the real world data have never replicated the 24-month survival with hypomethylating agents. So when I discuss with patients, I say a year and a half in real world. The SEER data is even less. So, and that had been created a challenge in the randomized clinical trial when we set the bar for 24 months. I think realistically, we are talking about 18 months, somewhere around that. The P53, I share that view, I discuss it with the patients. I think obviously transplanters argue that there is a tail at the curve and that there's around 20% cure still with transplant, but there's a very high chance of relapse. You are talking about almost 80% in the first year. So I make sure that the patient knows that, and that, sometimes I feel hard to push somebody to go through that with that 80% chance of relapse. Our approach, and this is again anecdotal or case series, we try to treat prior to transplant. Those that their P53 clears down, they seem to do better. So if I treated somebody with azacitidine or decitabine and they had a very good response, that the P53 allele burden went down significantly or undetectable, and they are interested in transplant, I'll go to transplant. But I make sure that the patients understand that, yes, there is maybe cure, but the chances of relapse are higher. I did recently calculate almost the number needed to treat with P53. You probably need to treat 20 patients to cure one with a transplant from the get-going. So we really have to be, I think, bringing more clinical trials, thinking of maintenance strategies in those patients, rather than just the reflex of transplanting every patient.
They're really great points, and I don't differ at all from the two of you. It is controversial whether or not to refer patients to transplant when they have a TP53 abnormality. There have been a number of studies that have looked at this, and the end result of it is that patients do poorly without a transplant with TP53, and they do poorly with a transplant with TP53. But there's this incredible temptation to send them to a transplant to try the most aggressive therapy possible to see if maybe that'll work. So I think we've fallen back in a number of discussions we've had about our patients with looking at goals of care and really having a very honest discussion with our patients about where the limits of our knowledge for referring them for treatment ends. Now, Rami, you mentioned before some clinical trials with azacitidine as a backbone. For years now, I think I can say that the three of us in particular have been working to try to come up with a combination therapy that can successfully treat higher risk MDS better than azacitidine monotherapy. Why have those trials failed?
Yeah, that's a good question. I think you wrote an editorial one time saying about the boulevard of broken dreams and the higher risk, listing all the phase 3 trials that were unfortunately did not translate to approvals. I think it's a challenging issue because we observe often high response rates in the phase 1, phase 2. Then in the phase 3, we don't even replicate that. I think really to translate to a survival advantage, yes, you need to increase the response rates and the complete remissions, but you also have to have durable responses. And I think the lesson we learned that we really need to have good randomized clinical trials. The last example is your study, AZA versus AZA pevindostat. Like the control arm, the azacitidine, did pretty well. Patients had high response rates. As you mentioned, people started knowing how to use those medications better. So I think the function of improving the survival really is, yes, higher response rates, but that are durable. Like as Dan even mentioned, AZA-VEN, and even in AML, you do get higher responses, but they are very short-lived. That in the P53 group, the overall survival was not different. So I think that's important. The other thing, sometimes I think we are being very ambitious that those studies are powered to detect a big difference, not small differences. And I think at one point we have to settle down that maybe a 2 or 3 month survival, median survival advantage is acceptable, but to power the studies as that, because our studies are not powered to measure, incremental improvements.
Yeah, I really like that last point that you made, Rami, about incremental steps to improvement in MDS. And if you think about it, these are such heterogeneous diseases that the idea that one drug is going to work across MDS fabulously, I think is short-sighted. And we can borrow from our myeloma colleagues and how they've approached treating another disease that's heterogeneous. Time and time again, we've seen combination trials where there's a 4-month advantage in survival for a combination, but the study was only powered to show an overall survival advantage of 10 or 12 months. So it winds up being a negative study. I think we really have to push as a community to power these randomized studies to show that 4-month difference in overall survival, and then take that as our next step and then start to focus on triplet therapies with that as a backbone. So, Dan, we mentioned earlier, there are 3 randomized trials of combinations versus AZA monotherapy that are maturing either later this year or early next year. And that's the combination of azacitidine and venetoclax, azacitidine and sabatolimab, and azacitidine and magrolimab. Which do you think will be a winner? What's your favorite of those 3?
I hope that all of them will be a winner. But how's that? I honestly don't know. I mean, I struggle. One of the things that you wrote about, Mikkael, was the idea that the use of these DNA methyltransferase inhibitors is important to not only start but also continue the use. And too often what we see in combination where you have doublets or triplets is that the toxicity, specifically when patients are being treated in smaller academic or community practices, so the duration of therapy is much reduced. And I think that's one of the differences in the AZA-001 study that you mentioned versus the decitabine study is how in the AZA-001 it was treatment with azacitidine until disease progression versus decitabine, it was response +2 and stop. And although there are many other differences between the studies, I think it's important. The way these drugs work is with continued therapy. And when you add another drug and you get more side effects, the temptation is to stop. And I think that's where and why, as Rami mentioned, we haven't seen or been able to reduplicate the outstanding results from AZA-001. But my hope is that they're both going to be positive, and maybe there's going to be some genetic differences between the two. For example, we already spoke about the TP53 with the venetoclax maybe not being at least an AML. Why would it be any different in MDS? Not an advantage, whereas there seems to be some biologic activity with magrolimab and P53. Obviously, we're going to need to see the randomized data to there. But our patients deserve to see some positive data, and so I'm really hopeful and fingers crossed.
Well, I want to thank you both and try to summarize what some of the things we've talked about in this session is the importance of starting patients on DNA methyltransferase inhibitors and referring them early to transplant. Also, the importance of maintaining them on DNA methyltransferase inhibitors and not giving up too soon. And we have some enthusiasm, I think, around combination therapies, and the hope that one of these 3 randomized trials that's going to be reporting out within the next year and a half is going to hit home. So thank you again for joining us for this segment on updates in the therapeutic management of higher risk MDS. Please be sure to click on the landing page for this activity to claim your AMA credit, access supplemental slides, as well as other topic segments and case scenarios. Thanks to my esteemed colleagues too.